Yes, so just to introduce the eHealth Core Facility. The eHealth Core Facility is a support function for researchers who need support to develop or test eHealth innovations. So we provide researchers with a wide range of services in digital health. This could be, for example, a platform solution for digital interventions. We develop and test smartphone apps. We provide solutions for online data collection. We can also analyze and store big data, or help with grant application in the field of eHealth, or just discuss ideas that you might have for future projects. So we arrange workshops or seminars such as this one. So if you're interested in knowing more about us, please send us an email or follow us on LinkedIn to see upcoming events. Here is our email address and the address for the website. Åsa, please, if you want to say a few words about KI Innovations.
Yes, so KI Innovations provide innovation support through the entire value chain. And that means that we work with inspiration and information. We validate potential in research and knowledge-based ideas. And we have an incubator for startup companies that aim to launch their product or service on the market or raise funding. And what we provide is advice and coaching. You can go back, Lee. Advice and coaching through our business coaches. We have access to some early funding from Vinnova. We organize short courses and seminars like this one, and we have a large network of experts, investors, and companies. Now you can take the next. And as you can see in this slide, we work with all kinds of innovations that come out of research at KI. And in the current portfolio, approximately 15% of all projects are within digital health. And next, so how it works and where to find us. All of our services are free of charge, and we don't take any ownership in the projects or companies that we support. If you would like to know more, you can follow us on LinkedIn. You can sign up for our newsletter, and you can, of course, contact us directly by email or phone. And we are located at Inomedicum at Nanna Schwarz-väg 2. So with that, I hand the word back over to you, Lee, and you will provide us with an overview of some different options in relation to implementation of digital health solutions.
Yes, so today we're going to talk about how to make your digital health innovation reach patients and caregivers. And this can be a difficult path, but as a researcher, you have several different ways of doing this. And this is just something that I'm going to talk briefly about before we leave the words to our speakers of today. So when we talk about digital products or health innovation, I just want to say a few words about the word product, because a product in this case does not necessarily have to be a finished product, such as an app ready to be used by paying customers. When we talk about products, we mean basically anything of value that has come out of a research product. It could be a ready-to-use smartphone app, for example, but it could also be data, results from research. It could also be content that is meant for digitalization, but it's not digitalized yet. It could also be know-how that you developed through the years. It could be a patent. Really anything that is valuable to someone who's interested in using or developing something similar to what you've been working on. So we have identified 3 different scenarios just to give you some examples of different ways researchers could make a product go from academia to healthcare, or actual patients or caregivers. And these scenarios are based on the involvement of the researcher into taking the product into healthcare. Because we know that some of you might want to start your own company, and others do not want to have anything to do with building a business or being an entrepreneur. So this is to show you that there are more than just one way of doing it. And I will just briefly explain these 3 scenarios. So the first one is when a researcher is not interested in bringing the product to the market themselves. This is when you either sell or you can also give away your product to someone else, and you don't take any part of the implementation actually. The second one is when you as a researcher, you want to be involved, but not to take care of every part of the implementation. We call this collaboration, and this could be with a private company or it could be with public healthcare. So it's a scenario where you collaborate with someone to bring a product to the market. And the third scenario is when you want to be involved in taking the product to the market and build a commercial product. So let's talk just a bit about the first scenario, the sort of minimal involvement scenario. As I said, this is when you sell or give away your product, and product in this case could be know-how or of how to use a certain technique, or it could be content, as I said before, or a patent. But in this example, say for example, you've developed an app with information for parents with children with diabetes, where they can track symptoms, learn more about diet and exercise. As a researcher, you're moving on to the next project, but what about this app? What do you want to do with it? So there are actually several value aspects here. The code is valuable. Also the content, the text, the images, but the know-how of how to organize the different components in the app is also something that is valuable. You could actually sell this to a private healthcare company, or you could give it to a patient organization, for example. But the point is that once you've given away or sold the product, you no longer have control of how the product is used. So even in this scenario where you don't want to commercialize your research, you should make sure to have proper agreements to regulate the use of the product. For example, you might have published results, so you want to still have some sort of control over the product. In seminar 3, next time, we will talk more about some different points that are important for some of these scenarios. So for example, what to think about when you give away the product, or legal issues here. But even if you give away a product for a good cause, so to speak, you still need to think about these things. So this is sort of the first scenario. You're happy with the research, but you don't want anything to do with the implementation. The next scenario is when you want to be involved, but you do not want to do everything yourself, but rather to collaborate with someone that can take your product to the market. In this example, say you've developed an algorithm for estimations of symptoms of COVID-19 from a certain number of parameters. And this has been piloted in a small primary clinic in public healthcare, but now you want to do an implementation study that will include a large number of patients. And you decide to collaborate with someone that can take some of the costs also involved in implementation. In this example, for example, you can do this collaboration with one of the digital healthcare providers, Doctor.se, for example, and they would have the financial and technical resources necessary, but you will have the content and the know-how, and maybe you will even have a patent for the algorithm. So in this scenario, you as a researcher will still be involved in the product, but you might have to adapt certain elements to the company you collaborate with, such as, for example, the logotype and the graphic profile. You also have to make agreements about ownership. For example, is it KI who will collaborate with Doctor.se, for example, or do you still need to create a company to be able to collaborate? Is this a research product? And if it's a research product or project, who will be the owner of these results? Is it you? Is it the company? Do you publish together? These are just some questions that are important to think about, and sometimes to get help with, because big companies have legal departments that write these type of agreements every day. And for you, that might be the first time you even see such an agreement. So here, we can talk more about this as well in the third seminar, but this is also something you should think about in collaborations. Moving on then to the third scenario. This is where you're an entrepreneur. You want to be a part of the whole journey. You want to create a product that can be commercialized. And we will soon have a great example of this when Björn and Henrik from AsthmaTuner will present their journey. But say, for example, in this example, you've developed a smartphone app and you register physical activity after stroke. And based on the progress, you give individualized feedback to patients. And caregivers get some information on the progress as well, and then they can contact the patients when it's necessary. And you want to bring this product to the market. And the market doesn't necessarily have to be individual consumers here. It could be, for example, the public healthcare. You want to make this product reach patients through public healthcare, for example. But in this case, the entrepreneur case, you need quite a lot of engagement. You need time, you need money, you need to start a company. You will probably bring others into your venture. Someone will be responsible for the technical development. You will have a CEO. You will probably try to raise capital from private investors at some point. This is a very exciting journey, but not all researchers are ready to put this much time and effort into such product. And as I said, we will hear more about this in a while when we talk to Björn and Henrik. So just to summarize, these three scenarios are not mutually exclusive in any way. You might have a combination, or you might move from one scenario to another, but this is just a way to give you an idea of some of the different options you have as a researcher that we can also discuss later on in more detail, depending on your case or your product. So now please let me introduce Emma Lovén, who is Chief Development Officer and CIO at Södersjukhuset, who will talk about implementation of new techniques from a hospital perspective. Please, Emma.
Thank you, Lee.
You want to share your screen?
Yes, I will share my screen. So my name is Emma Lovén, and as Lee said, I'm Chief Development Officer and CIO at Södersjukhuset. I'm responsible for a department called QMIT. It's a quality and business development, medical technology, IT, and hospital physics. And we are very much involved in implementing new technology into the hospital. And I'm going to talk a little bit about how we work with that. But if you want to take your technology to the hospital and make it beneficial for our patients, you need to find the future users and ensure that you have ambassadors in the core business. Some companies approach us in the support function, and for us it's very hard to determine if this is a product that our core business would like to use. So you need to identify which are the potential users of your products and what are the sort of arguments that would convince them that this product would be good for their patients. One of the challenges with this approach and entering into the hospital through the ambassadors in the core business is that the staff at the hospital, they usually have very little knowledge about the formalities of implementing new technologies into our environment. For example, they might not be aware of how the procurement processes work or which IT standards that we use at the hospital. And I see this many times when we have entrepreneurs and business owners that want to make their technology available to our patients. When we don't solve all these different questions that arise in the implementation, it creates unnecessary hinders and also risks for suppliers, and it usually makes implementation times very, very long. I mean, we have companies that have been talking to our core business for years and haven't yet been able to implement something. So we have established a process. It's quite new, this process, or it's an updated version of an old process that we didn't think worked very well. And the purpose of the process is to ensure that we have covered all the perspectives that are important early on before entering a big project and wasting both time and money from us and potential suppliers. And there are a few basic steps, and the core business, they come into this process with a description of an idea or a need that they have. And the first decision in the process is this a need large enough or important enough for us to actually put in time to develop? And then we do, if we think that this is something that would be very beneficial to the hospital, then we make a resource analysis. So we try to find out which questions are important to answer regarding this technology, and how much time would it take for us to have a pre-study or to conduct a pre-study to answer all the questions that are important. And then we make a new decision and we say, is the resource analysis or the need for resources, is the value still motivating that we should go further with doing a pre-study? And if we think that the value exceeds the resources described, we start a pre-study. And then we ensure that the different competencies are involved in the pre-study so that we can answer all the questions that we need to answer early. And if the pre-study is successful, then we launch the project to implement the new technology. So the pre-study is a very important step for us to evaluate the new technology. And we look at the necessary benefits and risks, and this will form the basis of the decision to start or not start a project. I can't see if there are any questions, but if there are, then feel free. No? Okay.
I have a question. Sorry.
Okay, yes.
I'm just wondering who is involved in this pre-study. Is it hospital providers, GPs, or researchers? What is
it depends, but usually it would be representatives from the core business, so clinical representatives, and also support functions, for example IT, and also the supplier. So we would collaborate in the pre-study to try to answer the questions that are needed in order for us to know if we can implement the technology or not. On this second slide, I've listed a number of questions. Not all of these questions are relevant for all cases, but many of them are. This is just a brief overview of what we want to know before deciding if we want to implement a new technology. And so we want to know, of course, if the technology is supporting the overall strategy of the hospital, and whether or not it's in line with other technologies that we have and fit into our technological environment. We have at the moment 400 IT systems at Södersjukhuset only, and our aim is not to increase the number of systems, but rather to decrease. So adding on a new technology is always a big decision. We also want to look at if the technology will increase patient quality or patient safety, because it's an important issue. And here we will also like to see if there's a dependency to other ongoing projects at the hospital. For example, if you have one clinic wanting to do some distance monitoring of patients, we know that most likely other clinics want to do that as well. So we might want to have one solution for distance monitoring and not 10 different solutions for our 10 different divisions at the hospital. So we will try to bundle needs and solve them in one way and not in 10 different ways. We also want to understand if the technology is solving consequences of new regulations or new laws, because then it's highly important for us and something that probably will be prioritized. We also want to see if there's a positive business case for implementing the technology. So will the cost for the technology be lower than the value to the hospital? As you probably all know, we have a strained economy at the hospitals, or all hospitals in the region, and we have to ensure that we are not taking on and adding costs, but also implementing the technology in a way that it reduces other costs. We also want to understand if there's a need for a CE certificate for this technology. Is this medical technology or IT? And if it needs to be CE certified, and if it's not, then there's a whole new different responsibilities that are introduced for us as a hospital, because then it will be treated as our own produced technology legally. We also want to know if the technology fit the technical infrastructure at the hospital. Sometimes we find the technology that needs Chrome as a browser. We generally don't allow Chrome. So if minor things like that can be a problem when wanting to implement new technology, and needs to either be adjusted or find a workaround. We almost always want to look at information security for the technology. Very often we face different cloud solutions, and generally we don't want to have patient data in the cloud yet. We're not there yet really in the region. So therefore information security is a very important thing for us when implementing new technology. We also want to understand how the technology can be procured and how we can maintain the technology and take care of it at the hospital. Do we need to set up our own organization to ensure that the technology is maintained? We also want to understand if we can find a budget for procuring and maintaining the technology. Sometimes we have long discussions with our clinical staff, and then we realize that they haven't secured budget, and then a lot of time have been spent in vain. And we also want to understand if we want to go ahead and implement the technology, what will an implementation project look like? How many resources do we need to have, and what activities do we need to run? I think there are some questions. No? Yes?
I can't see any hands, but we're not that many, so please feel free to just.
So can I ask a question?
Sure.
Yes, you can.
So Patrick Blomqvist is working with Åsa at Care Innovations. But I have a question. Which of these are the most critical things that people miss when they come to you with their pre-studies?
I would say the business case part is not always, I mean, usually it's the new technology is packaged as solving a big patient quality or patient safety issue. But the idea of how we are going to reduce our external costs in order to find budget to pay for the technology, that has not always been addressed. We always do an information security workshop with suppliers. They usually have good answers to the questions, but might not always be prepared for that. And also the technical fit into our structure, and that's of course very hard to prepare before you come in contact with us, because you can't know what our technical infrastructure looks like. But I mean, the infrastructure in IT in the region's hospital is not always suitable for modern technology. For example, at Södersjukhuset, we don't have a full covering in indoor network, so that anything that wants to run on Wi-Fi as a mobility product will have challenges in our infrastructure environment. And this is of course hard for a supplier to know, but many of the ideas fail on that.
May I ask a quick question?
Sure.
Thank you. For me, the most important thing is usability by users. And one part of that is the balance between security and access to the actual instrument. And then the second bit is the actual interface with the user. So that, for example, if you've got decision support or other thing, that you have a visual traffic light or a trend that makes it very easy to see, to make conclusions about, okay, what do I do differently now that I have this information? And I didn't see that on your list.
No, and I think that would be in the first phase, when you actually identify the users and ensure that you have ambassadors. That's when those issues are very important. When you arrive in our internal process and in connection to my department, for example, then we are not always that concerned with the usability, and we leave that to our core business to evaluate, because they are the ones that are going to use the products. But of course, you're quite on the spot there, that if you are able to present a technology where you have very, very good usability, then our core business will most likely be more attracted to that than if you have a hard navigated interface. Yeah, should we go on? I have just some short recommendations for you to be more successful into reaching us. And the first one would be to do your homework. As far as you can, prepare to answer as many questions from the pre-study checklist as you possibly can. Of course, there are some that require interaction with the support functions at the caregiver that you want to implement your solution with. Also ensure that your ambassadors involve relevant support functions in their organization to ensure smooth implementation, and do it early, before you have put in so much time in discussing the solution, so that you can have parallel tracks, both discussing user interface and usability, but also discussing the technical side of implementing and also the financial side. And then I would say adjust your expectations. Our budgets are very tight and our infrastructure is very outdated. So we might not have the funding to invest or the infrastructure to implement, even though we might find your solutions really, really good. So if you can help us to understand how we can reduce external costs within the same year, and also whilst paying for your solution, then you will have overcome a very, very big hinder for us to implement.
May I ask may I ask another quick question?
Sure.
It's slightly unfair because it's slightly off the topic, but it's so important and interesting. The last 8 months, we've seen a proliferation of solutions and apps and a whole variety of devices, not least of which is oxygen monitoring instruments at home, and et cetera, et cetera.
Yes.
What's your experience been with these, and have you adjusted some of your assessment systems or process to do this, or are all of these proliferating sort of outside of your radar scan.
No.
What's going on with all the things that people are doing, and which of these are you picking up and introducing and connecting to your system, and which of these are you sort of turning a blind eye to for the moment, especially given what's coming at us in the next 2 months?
I think it's a long question. I'm going to try to answer all parts of it. We have been very much involved in speeding up digital implementation during the spring and the summer and the fall. For example, when we realized that we could not meet each other physically I was a part of the crisis management team in the hospital, and we realized very quickly that it was not a very good idea that we all met physically in the room, every one of us who was in charge of leading the hospital. So we implemented Teams in like 2 days. We also had a solution called Alltid Öppet, which is developed by SLSO, and it's a way to interact and make digital patient visits. We had run a pilot last fall at one of our clinics, but managed during just a couple of weeks to put this solution in 140 installations at the hospital, and our target for the year was 5. So I think, and this has been run by as a project through my department. What we have been able to do is to focus on the things that have been of the most importance to our core business. And we've also made some adjustments to the demands and standards to what we require, and made some temporary decisions to use technology in a way which we might not use in a regular day. And this process that I showed you, it's actually a reaction to the very clear guidance from the core business on what's important, because the decision makers in this process to prioritize what projects we should do are heads of some of the largest divisions in the core business. And before this, we had a process where the support functions were deciding on what technologies to go for and what projects to not go for. And now we've managed to put the core business or the core organization in the driver's seat and make them tell us where to focus, which is something that we learned during the spring and which has been very successful. So I would say that we have been working in tighter connection to the core business regarding implementations of technology rather than just letting them do whatever they like. If that's an answer to your question.
I won't, it's a slightly unfair question. Thank you very much. Keep doing what you're doing and stay healthy, for goodness sake. We need you in the next few months.
Thank you. Yeah, more questions? Or someone wants to comment or challenge me?
So I have a question, Emma. It seems, I mean, this pre-study, it's a quite long and tedious process, I would imagine. How many, I'm just curious, how many suggestions do you get in each year, and how many products are actually implemented in just very...
It's a hard question to answer because there are several ways things could enter into our environment. Mm-hmm. Sometimes there are regional procurements of new technology, and then they enter into our system as something that we cannot choose not to do. Mm-hmm. And sometimes it's a regional, it might have been a regional procurement, or it might be a regional project that has been initiated that we want to take part in, or it might be an idea that comes from our organization. So it's a little bit hard to answer because there are several different buckets. But I think we currently in our project portfolio, which I'm almost a little bit embarrassed to tell you, is that we have about 90 projects going on at the moment, which is in my world too many, and we would it would be better for the hospital if we had fewer projects that we could focus more on in order to have progress.
Yep.
But those are not all technical projects. It might be business development or organizational development or process development or real estate projects and things like that. But it's still a lot.
Mm. And how many are you in your organization working on these questions?
On the medical technology department, we're somewhere around 35-40 people, and same number of people in IT. And in quality and development, we are about 10. And then in hospital physics, we're about 6. So, but not all of these work with projects. Many of them work with maintaining the systems that we already have, and not just all implementing new things. So if you look at the power, project management, power and IT project management, we're quite small organization. I would say less than 10 people.
Yep.
Can I just ask a question as well? You talk a lot about the pre-study, and it focuses a lot on technology and technical solutions. And I think researchers, we focus a lot on effect of the intervention and efficiency and usability, as we were talking about before. It seems as this is something that is decided much earlier on. So because I assume that you have to have some sort of positive results. You have to show that this is actually something that works. But do I understand it correctly? That is something that the ambassadors will sort of deal with. And when the project reach your stage, you sort of take for granted that the sort of aspects that deal with research results are already sort of solved. You don't.
The clinical,
the clinical aspects.
Yeah, the clinical aspects, we assume that the core business takes care of in evaluating. But there might be like efficiency aspects that we want to look at. For example, we have had a project where we piloted using a digital worker in one of our clinical systems. Or a digital worker, what do you call it? A software that is a robot and moves information between different views in the clinical system. That we did in collaboration between, as a pilot project, almost like an innovation project to prove proof of concept, because we had not tried to put a robot into our clinical systems before. We only tried to put them in support systems, which we have experience with. So then it was a collaboration between the supplier of the technology, the IT department, and the clinical side, where we all had different aspects of the project. And so we just finished the pilot, and we're finalizing the details in this project to see is this something that we could implement on a wider scale in the hospital. So it depends a little bit about what kind of project it is, or what kind of technology, and what we believe it will do for us. But often our clinical side, they have already ensured that there is some evidence of this working. They have talked to colleagues that have already tried it, or things like that, or they have looked at demonstrations of the product, or something like that.
So I just saw a question in the chat from Marina that is probably related. Do you have researchers involved in the pre-study? And then I guess that's related to your previous answer.
Yeah, if our clinical side thinks that there's a need for it, definitely. But it would not be something initiated from my department.
No.
I also have a question about, you talked about budget and budgets are tight and the positive business case,
Yes.
which I think as a researcher we're quite unused to having the business aspects of things. But I was wondering about the time span for a positive business case. Like what do you usually, what sort of time spans do you work with? Does it have to be something that is saving money from the hospital from day one, or is it a year from implementation? Or I suppose it changes from every project, but can you say something about?
Yeah, I mean, I haven't worked at Södersjukhuset for my whole life, as many of my colleagues have. I'm a former management consultant, so I'm pretty used to thinking in business case terms. And in investment terms, like you take a big cost year 0, and then year 1 you might not make anything back, but year 5 you have paid for it in like 10 times the cost of acquiring it. Here we need to, since we are on yearly budgets, the costs that we incur in a year we need to be able to finance within the same year. Otherwise it will be we have to find money from somewhere else. So that's a challenge for us when implementing technology that is really costly in the beginning. For example, there are some solutions that I could see would be really, really beneficial to the hospital, but they might not have a payback time within the year. They might have a payback time within 3 or 4 years. And it's really, really hard for us to find budget to do that. It has to be we have to find investment money. And then that investment money, that will be in competition with sort of life cycle management of medical technology and life cycle management of other infrastructure. So it's in competition with something that is already in the plan. So then you have to reallocate in the investment budget, and that's not a small thing to do. So if you could package your technology in a way that it's not very, very costly upfront, it would be easier for us to implement.
Yes, so that's an important aspect for researchers to think about early on, that if you want to have a chance of implementation, you have to think about these aspects, or how to find money for an initial cost if you still want to develop something that is expensive upfront.
Yeah, and I think we're moving into a world where more and more technology is paid as a service, and not, you don't buy like the hard or software and pay a lot of money up front, but you pay as a service, and that's actually helping us to pay for it, because then we pay when we use it and we don't pay up front a huge sum of money. So it's an enabler for us, and if you can think about a business model where you charge as a service, then I think it would be something that would ensure a smoother or an easier way for the hospital to find that money in the budget.
Do we have any more questions from the audience, perhaps?
I have a question. From all the projects that you get to evaluate, how often one actually gets selected and implemented at the hospital?
At the moment, we have a lot of projects that are required for us to do. So at the moment, we are not doing a large number of new projects. We have some regional procurements that need to be implemented, and we have some regional projects that are initiated when we decided not to go on in the region with procuring a new patient data system. And we have a lot of infrastructure projects at Södersjukhuset. We are rebuilding and remodeling some of our old buildings. So at the moment, our organization does not really have a huge capacity to take on new projects. But we try to do some small things so that our core business doesn't have or don't lose all faith in that we will have modern technology at our hands. But it's not huge at the moment. We have developed a plan, a roadmap for digitalization, where we have prioritized different needs over the years to come that we want to try to solve with new technology. Because we truly, from the technological side, we really believe that the new technology is what's going to enable us to cater for the increasing need of our population and the limited resources that we have. So we really believe that the new technology will be an enabler in this, but we have to ensure that we do our core business first.
Thank
you. But if you have something that would benefit a lot of patients or a lot of employees, so that we can apply it widely through the hospital and for different kind of patient groups, that will be something that would be more interesting for us than a very narrow product that only caters to small patient groups or a small number of employees.
Okay, thank you, Emma. I think if we have some questions at the end, we might have some time at the end. So if you have any more questions, please save them for the end. And thank you very much for this interesting talk.
Thank you.
I will now introduce to you Björn Nordlund and Henrik Ljungberg from AsthmaTuner, who will talk about their journey as entrepreneurs. Welcome, Björn and Henrik. Please share your screen.
Thank you. Thank you very much. Can you see the screen?
We can see my part of the presentation, but I think you have to.
Oh, okay.
It just looks the same as yours. I stole an image from you, so that's.
This one. All right. So how are we doing now?
Perfect.
Can you see the first?
Yeah.
See if we can switch here. Maybe. Yeah, there it is. Okay. We haven't rehearsed, but this is we're going to present a digital system for diagnosis and management of asthma. And one of the major challenges in clinical practice is just the gap between real-life asthma management and the guidelines. And the reason why we developed AsthmaTuner was to support both management and diagnosis. So we will try to give you an introduction on the solution and the challenges and some of the focusing on the milestones that we have accomplished. So I'm a nurse. I'm an associated professor at the Karolinska Institutet, but I'm actually employed by Astrid Lindgren's Children's Hospital.
And my name is Henrik Ljungberg, and I'm a doctor. I'm a pediatrician, and I'm specialized in pediatric lung diseases. So I see lots of patients with asthma, and I saw the need for the product. And that's when I, about 5 years ago, started talking to Björn about this idea, and we came up with the solution. And of course, it wasn't when you start. Some people start and they do a research project, and suddenly, oh, we have this nice product. For us, it was the other way around. We really needed the product before we could do the research, and it's kind of a lot of research in asthma and allergy is about cytokines and the inflammatory mediators, and this. So doing digital health in asthma 5 years ago was really uncool. It was like no one wanted to do research within this area. So we thought that this is really not so much. This is very clinical research. It's about helping patients, but we need we couldn't get any research grants. So this is one of the reasons why we started the company, was to get to be able to apply for Vinnova funding, and that's what we got. That's how we got our first funding from the BUX, which is Vinnova, together with Uppsala, to get the basic funding to build the first prototype product and start the study as well. And so that's what we spent a couple of years doing. 2016, we started with to implement this or do the study. And then, of course, working in the clinic as researchers, it's really difficult to either you're an entrepreneur and you go, this is what you talked about before, Lee. Either you sell your idea, or you try to get help from someone to build it, or you run it yourself. And of course, no one wants really. It's difficult to sell an idea, well, depending on the idea, of course, but and it's really difficult to build a company and still do research, which is very close to patients, very clinical research. So and it's also easier to implement something if you continue to work in the clinic and you have to say, well, you have to get patients to start using your system. It's easier if you're still working in the clinic rather than just stepping out, leaving your hospital job and then becoming a CEO and building a company. It's more difficult to get back in, so you have to knock on the door and take out your products and try to sell them, which is really difficult. So we both stayed in the clinical work, and we solved this by hiring a CEO and a head of product development at the same time. And really, the first thing that the CEO had to do was to find venture capital to pay for his own salary, of course. But once we got that started, we got a technical team started, and that's when we could really develop the product as we wanted it, and so on. So, and that's when we also managed to achieve the CE marking, which could be done because we had the clinical study, of course. And the first publication was last year, where we really published data, and we'll get back to that. And this year we had the second, or like the seed round investment, if you like, and we submitted a patent application back in 2015, I think it was, thanks to Åsa helped us with this. We couldn't have done that without you. And so this year, and just recently, last week, it was approved in China as well as a European-wide grant. So that's and it's still being evaluated in the United States. Yeah.
Yes. So the file of patent was something we did on a very early stage, but it took couple of years, as you can see.
Yeah.
As Henrik mentioned, we first employed the CEO and the head of technical development, Peter Sommer. And under them, we have this fantastic team. More than 10 people are employed. And then we have the majority are working on program development or developing AsthmaTuner. But we also have a team working with implementation and research and development. The majority are at the office here in Stockholm, but we have some partners working abroad. I think it's from Ukraine, a couple of employees. So this is basically the team, and they have different background and different expertise. But it's a really fantastic team. I think we accomplish a lot of things together with them. So what is this solution? I just try to give you an overview here. It's different interfaces, and one is that we call the patient side. It consists of a patient app and a wireless spirometer. This spirometer is not developed by us. It's bought from another company. The spirometer is connected by wireless, by Bluetooth, and all the data is stored in the cloud. It's a cloud-based solution, and the other interface connected with this cloud is the healthcare interface, enabling the healthcare providers to follow patients' data and take part of the management. It also enables us to develop healthcare decision support for management and diagnosis. Is something that it's on development, I would say, but it's in the pipeline. And if you just look at the process, how to start a patient, it starts with the physician prescribing a treatment plan, adjusted treatment plan, depending on there it is. It's in 3 steps, and then the patient can measure their lung function and register symptoms, and we call this a self-test to evaluate your asthma status. And the patient then gets immediate feedback on the status of asthma and recommended treatment to take. As you can see that you have a very clear instruction how to treat your asthma. And then the last step is to enable the healthcare provider to follow patient data and monitor patient's asthma. So,
and it's really about this is really about saving time for the clinician. For me, talking to asthma patients, and within a half hour you have to together with the patient to teach them everything about asthma and explain which inhalers to use depending on how their asthma is. And when you're sitting there talking to them, that when they come back in 6 months or a year's time, they're not going to remember everything. So the next visit a year later is going to be the exact same talk, and we keep doing that for years with the patients. And they as a patient, you don't remember what doctors or nurses say during half an hour visit, and that's the problem. And that's, if we take out all the teaching and put it into a nicely presentable format that the patient can have with them all the time, we can talk about other things during the visit, about motivation and what makes you motivated to actually use your asthma treatment. And it's not about which inhalers and to use when. It's more of a more efficient discussion, which also makes it's better for patients. Now, there are some other functions as well. We do PEF and symptom monitoring to diagnose asthma. We see that this saves a lot of time. We can diagnose asthma using this. Not the app, of course, and the software can't diagnose asthma, but it gives the data that can suggest a diagnosis easily by the clinician. And then there's the self-management, which helps in the middle, that helps patients treat their asthma better. It gives, you talked about before, I think it was John, about traffic lights, and you get, is your asthma green, yellow, or red? Everyone understands that. And it's pictures or images of your which inhalers you need to use for your asthma right at that time. And to do a full lung function test, spirometry, you can also use the system, and that's become immensely popular now during the pandemic, where for patients coming into the clinic and filling up their lungs and then blowing out as hard as they can next to a nurse is not really a popular or recommended even thing to do, even if you have face masks and filters and visors. So what happens here is that you can actually, using a video without the upbet, patients can sit at home and do spirometry, and we can see the results in the clinic.
Sorry, Björn and Henrik, I believe that we have a question from John. Would you like to raise that now, John? Or
yes, very quickly. Great work. But a number of these apps, like for example, diabetes and other ones, they sort of operate independently of an electronic health record. And I was just wondering, I mean, and a good thing too, because we wouldn't want to swamp primary care physicians with all of these data. But as regards alerts, where there are trends changing, where either a care manager or a primary care physician might need that information, you would need somehow to connect this system via a software which would trigger on alerts into a electronic health record, either in hospital or in primary care. What are your thoughts about the future for integrating these sorts of apps into information for physicians, either in hospitals or primary care?
Yeah, super interesting question. We spent a lot of time early on talking to medical record, or the providers of medical record systems, and asking. Everyone thinks that, yeah, we just put it into Take Care and you can see, everyone can see the data. It doesn't, like you said, there are no, you would swamp, there are no medical record systems that could provide for visualizing data that comes from that patients have collected themselves, like from asthma or diabetes. This is too much information. There's no graphics that could visually, even with the newest systems, they could never display it or use it in a useful way, even if it were to be integrated. And I think the turnover time is too long, and it doesn't really. We've sold it by doing printable or scannable reports that can be copied into text, or text reports that can be copied into the medical journals. It's the other question you have about the alerts and so on. That's also a very, some people want, some clinicians want alerts, and some don't, because if you get alerts about, if you have 1,000 patients in your clinic and you will get 200 or 50 alerts a day, you know, it's what you have to have someone that sits with it. You have to, but it's also, you have to remember, it's a self-management system. It's important. Most important thing is that the patient gets an alert, and if it's an emergency, the patient gets the information who to contact and where to go. That's, I think very few clinicians want more work and more information. We want more information when we see the patient, but we don't. We've also designed the system for patients to manage themselves better. So we put less, we make less work for the healthcare system.
I think that's absolutely the case, that it's primarily for use for patients, and then patients could bring in the data to show the doctor that would give them some more objective data if useful. I think the other thing is that I mean, there are two routes to develop these sorts of systems and devices. One is separate, in a separate system from hospital and other IT, and you just get on with developing it in a separate area. Or if you try and develop it within the hospital system, that's a whole nother way to do innovation, and much more time consuming and difficult given all the other things that the hospital IT folks have to do. So I can see for innovations and approaches like this that you just have to go an independent route and then worry about some sort of integration if appropriate later on. I'm raising this only because oxygen saturation monitoring at home using an app can alert the patient of a trend going down, which is a critical issue for getting to hospital. But many patients are not aware that their oxygen sat is declining significantly. And those monitors are very useful for that. But it's not really possible to connect that to the hospital when you want to monitor some possible patients where there's a high risk of their COVID getting out of control. So I think those two systems, run it on a separate system in the cloud and develop it and then worry about integration. That's the route to go for a lot of these.
Yeah, and the most integration that we've done is that to make sure it works on the hospital browsers, like Emma talked about. That's Chrome, of course. Everything works with Chrome, but it's really hard to get newer systems to work with Internet Explorer 8, for example, and it's because there's no support anymore except in hospitals. And it's what we've done is that we make sure it's a web-based system and the login for clinicians is the same as you would have for your hospital with eHealth or eTjänster.
Thank you, great work.
Yeah, I totally agree. The beauty of a cloud-based solution is that it's so easy to scale up and make accessible for different hospitals and regions. So this is, yeah, I think that's really good. This picture is the primary results from the first clinical validation. And as someone mentioned, we were very interested in see the effect on patients. What happens when they use AsthmaTuner? This is a randomized control 8 weeks crossover trial, which means that the patient was randomized to start either with AsthmaTuner or conventional treatment using a printed treatment plan on paper. And then finish with in the next round they finish with the conventional or AsthmaTuner, vice versa. So the asthma control test is a very simple 5 questions that the patient answers when they meet up in the hospital. It has been validated, and it's a test of measuring symptoms. So we use that as the primary outcome. And as you can see here at your right here in the figure, we saw a very clear sequence effect, which means that the first period was improvements in both groups, both in AsthmaTuner and the conventional group. Then in between, it was a washout period for about 2 to 4 weeks. And then the last period, we saw some slight differences between the 2 groups. I also would like to mention that all the patients here in this study were uncontrolled. So that was an inclusion criteria to be included. So by comparing the both groups, we saw a significant effect on symptoms in the group that when they used AsthmaTuner compared to conventional treatment. So this is a study conclusion, and in addition to that, AsthmaTuner improved symptom control in patients with uncontrolled asthma. We submitted an application to the authority Tandvårds- och läkemedelsförmånsverket. I think if you translate it, it's the Dental and Pharmaceutical Benefit Agency. And they combined the results from the effect of AsthmaTuner with guidelines for management of asthma. And they concluded that it's likely that the number of healthcare visits could be reduced for those patients to whom the use of AsthmaTuner leads to better controlled asthma. So this authority now we have a subsidy for the spirometer for children up to 18 years. And I forgot to mention that the first study here included both children and adults. The children from secondary care and mainly adults from primary care. So the data pointed that the effect was larger in children than in adults. But we also saw, of course, we also saw effect in adults as well. So this was very nice. And lastly, this was the second clinical validation that we published this year. And it was about the diagnosis. Time to diagnosis was the outcome. And this is a well-established method for diagnosing asthma, as Henrik earlier mentioned, and it is to look at each point, each measurement, lung function measurement. You look at the serial of measurements, and if you have a variability in lung function, it confirms asthma. And this is a method that has been used for decades, but there are some challenges with the adherence because it requires that the patients consistently for a period of time up to at least 4 weeks measure their lung function and register symptoms, and that could be a challenge. So what we did here, another challenge with this traditional method is that you need to bring the data from a paper normally and into like an Excel sheet, and then from that sheet calculate the variability. And that's as well is very time consuming. So what we did here was we compared AsthmaTuner with this traditional peak flow meter and using a paper. And the outcome was time, as I said, and one was time to decision. Either you could decide that this is asthma, or rule out asthma, or take a decision that this patient needs further follow-ups. And the other outcome was time for analyzed data. And both these outcomes, we could demonstrate that we save time by using a digital tool for diagnosing asthma. Yes. Then we would like to go into the municipalities and regions, and I think this is quite important to stakeholder when it comes to implementation. Of course, we have Emma talked a little bit about the budget and all these things that are important when it comes to implementation. But one challenge or step back that we ran into was the data, how we store data and handle data. Of course, this is a cloud. There were, or still are maybe, some concerns about the storing data in a cloud. the main question, I think, is who is responsible for data? And that was something that the Swedish Sveriges kommuner och regioner, which is not authority, it's I have learned now, it's
interest organization.
Interest organizations, yeah. And they decided, because we got this subsidy for the spirometer, they were very concerned about the data storage. So they wanted to, they first said that they couldn't recommend AsthmaTuner despite all the effects that we have published. So that was a setback. And they did that without even analyzing the solution. So that thing I just want to highlight here is that this is a very important stakeholder, but they very nicely performed an assessment of data protection and compliance to data protection in AsthmaTuner right after they came up with this decision. So what they did, they looked into the Swedish laws and the regulations and assessed how AsthmaTuner complies with GDPR. That's on the patient side. And on the healthcare provider side is the patient law, data law, PDL. So quite after like a couple of months or something like that.
Yes, quite quickly then.
They said that yes, we now can recommend AsthmaTuner for the regions and the municipalities.
Yeah, so that was very important, of course, and like a benchmark, like a quality mark that we got from this because they hired the foremost lawyers to look at this, but still some regions are still very worried about this storing data in the cloud, and have some very interesting ideas where data should be stored and so on. And I mean, we want to do what's best for the patient and where we think the data is safest. I mean, if it's safer on a hospital server, that like you said, Emma, the hospitals don't always have the newest IT systems, or is it safer on the Microsoft solution where you have 50 people working day and night to stop any hacking attacks? You know, there's you can talk a lot about the cloud-based data storage, but which I don't think is the focus here. So
can I just ask a question about this, because I think this is like you said, it's an important step, and it's also something that could be a setback and you have to find your way around. Is this something that you asked them to do? Did you sort of approach them and say, could you come to a decision regarding this app? Or is it something that is completely like an independent process where they just all of a sudden
it came they started this analysis first, or they didn't do the analysis, they just said no, because that was because the TLV, we got the reimbursement, and the reimbursement is really a recommendation that to start using it. And then they said, well, hang on, we haven't been in the loop. We usually talk to TLV and Astra, usually have a dialogue about which products should be reimbursed. And so I think they were a little bit jealous and felt, you know, bypassed, and they wanted to do. They started off by saying, no, this has to be analyzed, and then we reacted, of course, and we said this is a little bit unfair because we think it's safe, and they had it investigated by their lawyers and found that yes, no, this is a safe system for.
So they sort of took care of that, like they financed that.
Yes.
That themselves. You didn't have to do that. Okay. Just a question.
Yeah, and the reimbursement, this was the first product that was reimbursed.
Digital health product, yes. First digital health product.
So it's important to remember that as well.
in Sweden or in Europe, probably, to be reimbursed. Yeah.
So you're in the front line here. really taking the hits for all of us. That's great.
And I think this is well worth to mention that the Swedish Kommuner och Regioner is a stakeholder that everyone should consider that wants to implement digital health solutions.
I mean, we work with patient organizations, we work with clinicians, we work with international guideline writers. We work with, and I think SKR is one of the organizations that when you get to a solution, now we have thousands of asthma patients using the system. It's important to keep them in the loop because we are active within quite a large number of regions in Sweden now. So it's important to keep them informed as well.
Yes, and then we skip to another thing. The very important thing is the funding, and we would like to highlight the different organizations and that had helped us, supported us. First, as Henrik mentioned, the Vinnova and VOX, and also Karolinska Institutet Innovations AB, as well as SLL Innovation. They were very crucial in the beginning to bring up the first prototype. Then for the research, we have applied from the Patient Organization Research Fund, Astma Allergiförbundet, a Swedish Heart and Lung Foundation, and also from Eurostars, the EU funding. And for the company, there have been this second round. The main investor is Almi Invest, and along with the private equity that has been involved in investment in the company. But this, I would like to just separate that. Investment for the company is one thing, and the other is the research is the funding there is mainly stored or it's something we use here at the hospital or at Karolinska Institutet.
So I want to say that, sorry to interrupt, but you just have a few minutes left of the time we have. Sorry. Just so you know.
Last page. This is just some publicity. So this is something we would like to bring forward to try to get some publicity and apply to different challenges. That's a good way of getting publicity.
Thank you. I think we have time for one question, perhaps, if anyone. Thank you very much. I think this is, as I said, when introducing you, a very exciting journey. So it was really nice to learn more about all the important steps that you've taken in becoming Europe's first reimbursed digital healthcare provider company.
But not the last.
Yeah.
No, not the last. Do we have any questions from the audience at all?
On to the next meetings.
Yes, I'm just gonna share, I think, Åsa, if we don't have any more questions, I think we should thank everyone.
Yes, thank you everyone for participating, of course, and Emma, Henrik, and Björn for sharing your experiences. And in 2 weeks' time, we will continue to discuss some of the aspects that you should think of at an early stage, including legal and regulatory aspects. So thanks again. I hope to see you in 2 weeks, and take good care.
Thank you.
Bye-bye.
Bye,
Bye.
everyone. Så spelar vi fortfarande in eller?